I'm going to start the recording and then we can get started on our. Oh, I guess the recording's already going on. Fantastic. Started automatically. Oh, easy peasy. So yeah, today we'll be discussing the sort of standardized case report form, which we had chatted about last month as well. So thank you to everyone who has commented and edited that document. So what I've done is I've gone through and I have cleaned it up a little bit based on people's comments and edits, but I've left certain comments there for discussion, ones especially the ones that were more open-ended. So what we can do today is go through that document again, try to clean it up, deal with the ambiguity as much as possible. And then what will follow this is that I will send out a form to everyone who's kind of in this mailing list to help sort of rank in order of priority within each section what might be important to collect. The reason we're doing this is because, some people can't make these meetings, may not have had a chance to comment on the document itself, but this could also be a good way of understanding what kind of data is feasible to collect in certain institutions and what isn't. So things that are kind of ranked as high priority would be more important to collect in different places, and versus those that are ranked as low priority either might not be possible to collect or are not seen as nearly as important, because you'll see our case report form is quite long. So we understand that not everything is possible to collect everywhere. So that priority ranking would give us an idea of what elements might be more important than others. So it's a good sort of, I guess, kind of standardized researchy way to understand what can be collected. So that will follow. But for today, we can just share thoughts again on the form itself. So what I will do is I will share my screen here. Okay, so hopefully let me zoom in a little bit so people can see better. So this form, for anyone who's seeing it for the first time, the idea is that we are creating sort of data collection standards for snakebite patients. So this form is meant for observational studies conducted in clinical settings. So you'll see it's very much geared towards a hospital setting for snakebite patients. The idea here is that, there are many people who attend these calls, and snakebite research in general, much of it is conducted in hospital settings. So if we can kind of leverage that routine data collection into a standardized process, then this will help not only individual institutions conduct research, it could also help people collaborate if we're collecting sort of standardized data. So that's the idea here. So we've divided the form into 4 sections. The first one is on patient demographics and clinical conditions. So once again, I tried to clean it up based on people's comments. I'll scroll kind of slowly through. If anyone has any sort of leftover feedback or things to add, feel free to jump in as I'm scrolling through. For example, highest level of education. This is there was an external link that someone had put in. So we tried to put standardized categories as much as possible. Oh yes, Kwaku, go ahead.
Okay, thank you. So for the education, I think you can safely end at just a university education. And then going to master's, doctorate, you often not find any person in that area. Not you like at the analysis stage, you have to look them like sort of
Yeah, that's a good point. It's kind of all practically means the same thing.
Yes, I actually agree with him too, because university education can be first degree, second degree, or even the PhD level. So all of them are university education. And in fact, it's even true that most of our patients practically you hardly get those with the higher level of degrees with snakebite actually.
Right.
Thank you.
Thank you. Thank you. And next we had, so noting that this form will be kind of in many different settings, we have different levels of granularity for where the patient is from, and also trying to avoid putting exact addresses because we want, in case people use this and then collaborate with another institution, it's probably good to maintain some level of confidentiality. Then we have residence category, urban, rural, peri-urban. We have comorbidities preceding the bite. There's one person who had recommended removing history of bleeding disorder, but I tried to add tried to be sort of more specific about this. So what do folks think? Should we maintain this or should we delete? Yes, Dr. Mani, go ahead. And Kwaku.
Hello. Yes, I think we
Hello.
can leave it. I think we can leave it because mostly in papers, even in reviews, you discover that most of the viewers will even ask you whether you have any record of history of bleeding disorder, because it's most likely studies have shown clearly that history of bleeding disorders also are associated with poor outcomes in snake bites. So I'm of the opinion that we should just leave it to be beneficial. Thank you.
Sure, thank you. And Kwaku, did you have your hand up or was that legacy hand?
I would have said same as you're seeing. So
Okay. Yeah. Sounds good. We can leave this here then. And there's an other field if people have more sort of detail to put. But for the most part, we've tried to minimize the number of free text fields here. So we're trying to minimize the use of other as much as possible. So for employment, there's one suggestion to add a point about whether the person was employed part-time, full-time, or unemployed, and then a separate question about occupation. I was wondering if someone's a housewife, for example, which is under occupation, would they be considered? I wasn't sure what bucket they'd fall into. So is it confusing to have this as a separate question, or should we leave it in there?
okay. If I can also, I think I said in one comment that as often is the case, it's not the person's employment per se, but the
Yes.
activity the person was undertaking at the time of the event. So it looks okay. It looks okay to me since maybe there's one on the activity which immediately preceded the event.
Yeah, no, it's exactly as you said. I think this is more just to assess things like financial status. So I think it was Beth who also made a point of if the patient is a minor, then we'd recommend documenting one of the parents' occupations instead. Yeah, because yeah, as you said, there is a separate sort of activity question.
Hello.
Hello.
I have one question about this area.
Yes,
what is the
go ahead.
difference between status and occupation? Both are to integrate one employed part-time. It is an occupation part. So it is confused two parts.
Yeah, I
me.
think this is more to understand if someone pursues this occupation full-time or not. So sort of a two-part question almost.
In our case, it is not applicable,
Okay,
both
okay.
of. So, good.
Yeah, we could even, another way we could ask this is if we put in unemployed, retired over here as a category. And then we sort of have a follow-up question for if known, like was the patient employed part-time or full-time? That is also an option. We can do something like this. Something like oop. If employed. Yeah, something like that.
But I mean, where is the question for the employment then? Before if employed.
That says if, I guess, if occupation isn't unemployed or retired. Isn't. Then this will only appear if this question equals unemployed, or sorry, if doesn't equal unemployed or retired.
Okay.
But then in addition to that, we have some other questions that could probe for instead of, and we had quite a big discussion about income last time, and there were quite a few comments left on this as well to say that income is quite difficult to standardize in different settings. So one of the suggestions was to use other sort of proxy questions to understand income level, things like house flooring type, toilet type, and household water source. This is something that's a little bit more concrete, perhaps, and easier to understand someone's socioeconomic status with. So I wanted to see what people think of including these questions rather than asking a simple income level question. Wait, Scott,
Hello?
go ahead.
Well, I don't know. Are there references that actually point to how we can use those specific things to classify the socioeconomic status of the patient? Because I think it's important we have references that back up this specific classification because it will actually help us to have a very good a standardized form of reporting it. Thank you.
That's a good point. I think these ones are dimensions of I think it's the multi-dimensional poverty index, if I'm not mistaken. So there are sources backing up these. Kwakwe, I see your hands up. Go ahead.
Okay, you are right. So we are from the multi-dimensional poverty, but it's very outdated. The thing is, somebody may have a laptop that doesn't have a TV.
Right.
And then again, if you ask me the flooring type, and I see wood, it may be because luxurious, I live luxuriously, or I cannot afford. Because when people are so very rich, they end up using wood, and when they are poor, they also use wood. It's all in the nature of the finishing. So I would say we should go with if the person can tell the amount he's earning, it is easier to then do maybe what is the relative income size in the country. If you are poor in Ghana and they say you are poor in the United States, I guess anybody anywhere will understand it
Mhm.
in the same frame that you are poor. If you are poor in the US, it doesn't mean you can afford a Lamborghini. It doesn't
Right.
work that way. So I think we should ask the hard question. How much is your income relative to your income? Maybe you probably put yourself in that area rather than trying to estimate by property.
Right. So something like this, like it'd be totally subjective then, based on their own sort of knowledge. Whether they earn like either below average, average, or above average compared to their area of
Hello.
residence. Hello.
How to measure the average? Depends on the country. How to
Yeah.
measure. So average and above. It is better to put by dollar or other currency. So it is
Mhm.
difficult to measure. It
Yeah, this
depends on
one's
country.
yeah, it also depends on, I guess, within the country. So like the US is a good example. Something that's average in one part of the US is totally different from
Yeah.
what is average in another part. So maybe, I don't know, maybe income is just a little bit too complex to judge. So should we include
Yeah, I agree with
anything
you, but
about income? Mhm.
I agree with you. And at least if I can convince you, I hope I mentioned your name correctly. The thing is, if you say you live below the poverty line in
Mhm.
your country, everywhere you go, you live below the poverty line. Well, it may not be in this on the same scale, but at least if you try to use a single currency, and especially when the exchange rates can fluctuate. So I think going with a perceived income level
Mhm.
that my income is on the average. If
Mhm.
somebody in China says my income or India says my income is on the average, we all know in both instances the person cannot afford luxury every
Mhm.
day. Like somebody who says my income is above the average or very high.
Right.
So just in a way that the information can be standardized across different settings, that is where I would support the idea of such a classification.
Mhm. Yeah, we are quite clear to say perceived. So something that, so this entire question, there's no absolute amount. So according to you and what you perceive your own income level to be, then the patient can answer this question. So in that case, should we leave these there? So there's some other sort of objective measure, noting, as you said, Kwaku, that some of these might be kind of out of date.
Yeah, and if I can put some more nails in the wood.
About
For
country and the
instance,
income level, it is
Mhm.
better to put low, medium, and high. It depends on the country. The socio-economic is finalized by this measurement.
Mhm.
Low level, medium, and high income level, it depends on the country. So it is not important socio-economic status, house flooring. Most
Mhm.
the snakebite patients are in our country the daily laborer and living in under poverty. So they
Right.
are harvesting collector, shepherd, and others. So mostly it is down on the poor income level. So
Mhm.
it is by the socio-economic status it is measured to by these three variables: low, medium, and high.
Mm-hmm. Yeah, that sounds good. We can leave it as low, medium, high. Perfect. And then following this, I think it was Kwaku who mentioned marital status. What may be relevant is just to know if, not all the different statuses, but rather if someone is married or cohabiting a place, or if they're single, divorced, widowed. Other categories might not be so relevant for snakebite. And same with pregnancy. I've added one section of pregnancy outcomes at the end, in case somebody selects yes for pregnant. Before we jump to section 2, are there any more comments or concerns with this first section of demographics? If not, I will hop over to section 2, which is circumstances of snakebite. So this also had some comments on, whether this is the person's not only just snake bite, if they've had snake spit on them before. We should include that as well. So we had a yes/no question here, and then if the answer was no, this is not the patient's first snake bite, how many times has it happened before? So this kind of gives an idea of history of snake bite. We also had date of bite to establish some seasonality. For the time of bite, we had exact time if known, as well as approximate time window. Beth suggested these as time windows because this is things that people can remember, especially if if it took a long time to get to the hospital and the snake bite happened quite a while ago. These might be kind of relative timescales that people remember. And we also had activity that the patient was partaking in when the bite occurred. So we have various various farming activities, animal herding, sleeping, playing, walking, swimming, military training or exercises, and then a sort of other if there are any things that were missed. This was the snakebite provoked, had quite a bit of a discussion, so I left it here so that we can kind of discuss and finalize today. Basically, I guess the discussion was about whether or not to be more specific about this, if the snake was sort of if the patient attempted to kill or hit the snake before they were bitten, whether we should use provoked at all, because all snake bites are kind of provoked, or most of them. So there are, I guess there are some comments and insights on this. So if anyone has anything to add, we can chat about it now.
So I think I would say it's okay because yes, they are all provoked, but not in the active sense. If I'm walking to my farm and I happen to be bitten by a snake, I didn't provoke it. Of course, it's a provocation, but I didn't even see it. But if I see a snake and I attempt to kill it and I get bitten in the process, that's a provocation. One that we, so I think it is okay this way, and that's my opinion.
Yeah, it sounds a more active provocation.
I think that's clear because initially I was part of the people that actually contributed in that discussion because I was thinking that when you're talking about provocation, it's more relevant, especially when you talk about dog bites. That's when whether the case of rabies or not. But I was actually, Beth was able to explain clearly, and that's even exactly what he's trying to say now, that attempted to kill or hit the snake. Yes.
That sounds good. Then we also have place of bite occurrence. There's quite a few options here, but again, there's like an other specify if it happened elsewhere. If was the snake killed, yes or no? Somebody had also.
Hello,
Oh,
Aashna.
hello,
Hello,
yes.
Aashna.
Yes.
Currently at the workplace, as it
Ah.
happens, yes.
Then we have snake length that someone had suggested adding, I guess, if known. For the picture of the snake, there was one field to say upload a picture of the snake, but I think many people might be documenting these by hand, so it might not be totally possible to upload a picture of the snake.
Well, it is. We are running a project where we are getting some pictures.
Yeah, should I add that if?
Yes.
Okay.
And the length, kindly add a note that not there should not be an attempt measure. Steady. The snake may not be dead, and in people's energy to get the picture, attempt to measure and get bitten. So no attempt. That's what we did in ours. There's that note that they should not make any attempt to get the image if they to get the length if they can find, if they cannot, because there's no compensation for being bitten.
Yes. I can make it clear if measured. What was the length and picture? For snake identification, this one's a little bit tough because somebody had suggested adding this because some people recall the color or colors of the snake that they saw, but can't necessarily remember what kind of snake it was. So someone had suggested kind of having a two-part question to assess if the patient can remember what color was the snake or if they have a photo or something. And then quite generally, what kind of snake do you think it was? I know these are very, very broad categories. This is supposed to be a very general form, but we can perhaps have an additional field where you fill out the exact species if known. And then someone can add the exact species depending on where they are. But what do folks think about having a sort of multi-part snake identification question?
I'm a bit worried because we have metacrosis, that is the ability of a snake to change its color based on its environment. So
Okay.
it's possible we can have carpet viper in another place, depending on the environment. It can have a different color again, another environment based on its environment. And I think it's important to note that. So I'm just thinking, I'm worried about these colors because colors cannot be definitive of the type of snake because of metacrosis.
That's a good point, actually. Maybe we could get rid of this one then, and then just rely on, I mean, worst case, people aren't able to identify the snake species, and that's fine. But perhaps we can get rid of this if it's not really informative. And after the snake species, we have anatomical site of snakebite. There are a couple of different ways we've thought of doing this. One is just simply selecting the site of bite, and another one is we'll have a body map, and then people can kind of circle where the bite happened. So this allows them to be quite specific about where the patient was bitten, but also you can kind of you can confirm with the two questions. Here we have some questions about what happened before the patient came to the health facility. So I know there's some discussion and there are quite a few comments about this. So the way I've structured it now is that any question related, I think Kwak would also suggested this, any question related to traditional treatment is kind of within this section, and those questions only appear if someone selected that they visited a traditional healer. So our first question asks if the patient came straight to the health facility, simple yes or no. If they did not come straight to the health facility after being bitten, there are some options for what happened in between. I think Beth had noted it's also important not just to think about traditional healers, but if sometimes patients visited other community clinics before the clinic or a larger hospital. So we can select kind of all that apply, and then if they visited a traditional healer, then other options appear. But I see there are some questions. Kwaku, go ahead.
Okay, I would say if they visited a health center or a community clinic, it should be separated from if they visited a traditional healer, because the community clinic and health centers are formal places where adequate treatment have been given, and to mix it with the traditional healer, so I believe some information will be missing. So if they visited a traditional healer, a herbal medicine, or those will be separate. But then the case pathway will be if they visited a proper hospital before, or a proper health facility. Because even referral is, how do I even say it? It's a proper medical decision to make that this case must be referred. That means they have more time than if they go to a traditional healer who do some strange things before they refer.
Okay, is this the first? That's a good point. Health facility. Then we can separate it entirely. To the, okay. So then, yeah, we'll separate it entirely, and then we can say what care he.
Yes, they even dress the wound in another sense. So
Sorry, you cut out for a second there. What did you say?
I was saying if they visited a health facility, their wounds may have been dressed.
Right,
Maybe
right.
the first dose of antivenom may have been administered. So
Yeah, that's a good point. Then in that case, they can just choose between whether they kind of did something to their own bites, visited traditional healer. And then if they visited a traditional healer, we can ask some more questions in terms of what happened there, what kind of treatment they got. Someone had also added that it's important for us, if possible, to track cost of treatments. So that includes cost of traditional treatment. So I've added a couple of those here. I mean, of course, if known. If not known, then don't fill these out. But if known, it would be good to document the cost of those treatments. Then we had approximate time taken to get to hospital after being bitten. Now that we kind of know what happened between the bite and the hospital, that should provide some context for this. However, I noticed someone had recommended recording this in minutes instead of hours, so I wanted to see what others think. I thought minutes might be too granular, so people might not remember how many minutes it took them, but What do others think?
It's okay. It needs to be, within 40 hours, the open is converted to minutes. The reason being, a lot of people report in less than an hour from what I've seen. So you can
Wait.
easily avoid, you can easily avoid lost time, because when you're analyzing, you have to use 1 minute. So instead
okay.
of padding time to 45 minutes and making it 15, if you measure in minutes, you don't lose that much data.
Okay, so we can change to minutes.
I think in our own setting, when we see a patient that's reporting less than an hour, we usually clap for him very, very, because you hardly see that.
Mm-hmm.
Mostly we see patient that reports more than most of us reports more than an hour. We hardly see that actually. We have to clap for you actually. Once we see that you're presenting less than an hour. So I think but nevertheless, I still believe that once we leave it in minutes to encompass every other person, rather than actually starting with the hour.
By the way, which country are you? Are you?
Yes, I'm from Nigeria.
Oh, that's my neighbor.
Sometimes before they come to the hospital, they have to visit traditional healers. They will receive so many medications. They have to try. Usually, hospital becomes like a referral center. That's after maybe you've lost confidence in what you're already doing, and then you decide to come to the hospital. And of course, community engagement advocacy has been improving that, but still, these same people will still come with something rough on their skins before coming to the hospital, because they believe that it reduces the envenomation before we reach the hospital.
And one of our physicians was discussed. Sometimes even when they come early, it means they are at higher risk, because they are running to get to the hospital, increasing blood circulation and fastening the envenoming process. So if they rather sort of took their time and the moment sort of running to the hospital, we were just laughing about that. But I think there's that real issue of what is the appropriate time. I guess we will look at that another time.
This is interesting, actually. It's true. It's very interesting, but it's actually true, because the higher the activity, the more the spread of the envenomation. And of course, so the more they come, if they run to the hospital, that means you are handling a case of an envenomation that has spread very fast. This is very interesting. I like this view actually. Thank you.
I guess it's different contexts.
Yeah, I think I would suggest to keep it in hours and give the categories and probably group categories of hours. As you had earlier said, minutes would be too granular. And in most of our setups, seeing that my colleagues from the west side of the continent also say that rarely do you see people presenting within that time period. Most people present hours after the bite. And then we are also cognizant of the fact that in rural setups where most of these bites take, transport challenges are there, barriers accessing access to care. So even if they want to get the facility, it will take time for them to get to transport facilities to take them there. So hours will be more feasible in this setup.
If I may, so
yes, go for it.
the person gets bitten. The person gets bitten. They have to get to a hospital for treatment, but they report to a lower facility. So between the bite and reporting for medical care may actually occur in minutes. But at the time that they would get to the hospital for proper medical care, that's when the hours may have elapsed. I can also get it. We need to like have a form that is universally applicable and other things. So if hours, the issue that sometimes occur with hours is where the person came, if you it's like 2 hours, 30 minutes, you are forced to record it as so that long that's when me certain things that are happening. Thank you.
Thank you. You cut out for a moment there, but I think perhaps this could be a compromise if we have two fields. Somebody can put in a value as well as a unit. So depending on the context, if you're kind of working in a big hospital that people can access quite readily, then you might be able to record in minutes. But otherwise, if you're in a rural setting, as Paul said, it might take you hours or even days to get there. So we can kind of leave it open-ended so people can fill in what works best for their setting without losing information. Someone had also suggested putting distance from place of bite to hospital if known. I know this isn't always known, but if known, that could also be informative, as well as how the patient got there. Mhm.
I think if we may actually be able to replace the distance of the time it takes to travel to the facility.
Mhm.
So even if it is 2 kilometers, but you have to walk, you have
Right,
no
that
other
would take
option than
long.
to walk. Yes. So the time that it takes them to the facility, I think helps more than then we get back into the other one. Are we going to record? Okay, maybe we can just use the same compromise.
Mhm.
Did it take them minutes, hours? Okay. I don't think anybody has to work the whole day for healthcare. It's possible.
Yeah, that's a good point. And we have here a way to record kind of how they got to the hospital. We could help contextualize.
No, but I think the question, if you could, the one you remove, replace so that how long it took them to get. Okay, there's the approximate time to get to the hospital. Sorry.
Yeah.
So that's already
Yeah.
accounted for.
Correct. And then we have how they got there. Again, if possible, we can track the cost of transportation, as someone had suggested. And we have a simple yes/no question for if they were admitted. And then the next section, I recognize we don't have a lot of time left, so I'll speed up a little bit. The next section, quite a few people had said we can, I think Kwaku, you also said, we can have so the following categories for symptoms, laboratory assessments, things like that. We can have ask people to fill them out at presentation, and then if possible, we'll kind of have daily columns available. So as long as a patient is in hospital at least once a day, these things should be recorded. Again, if not possible, at least at presentation, we should know what the values of these are. And there are, I've tried to separate them into sort of laboratory-based things, local symptoms, and then systemic symptoms. So there's the blood clotting test. It's also cell volume for sort of diagnosis-based things, and another laboratory-based test would be bacterial infection. For all of these, there's an option for test not done because not every place has laboratory facilities that can enable these tests. So that is there. And again, if a bacterial infection is tested for and comes out positive, then there's a field to document what kind of bacterial infection it is. And then kind of one by one, we kind of go through each of the symptoms, just simple yes or no questions to document if any of these local symptoms were present, And then the same thing with systemic symptoms, which are divided further into general and then kind of system-specific symptoms. We'll kind of scroll through these. We have neurological symptoms, hematological symptoms, and I think renal is the last one. There we go. So that's yes,
quickly.
Go for it.
If we can move the systemic symptoms before the general symptoms, well, these are more likely to occur. We don't need to do it now. Okay, so once we do it, I realize we don't have any Australian. Don't you think it's not fair?
We don't have any what?
Australian.
Oh, on the call.
It's not fair.
That is a good point. We do have there is representation from Australia in the hub, but I'm not sure if anyone on the call right now is from there.
We should find one and abduct the person.
Yeah, it'd be good to get as much sort of regional diversity as possible in reviewing this to make sure it's, applicable. So yeah, and again, I'll make sure I think everyone here has access to this document. So once again, there will be an opportunity to add things that we might have missed. So after the symptoms, there's a third section for in-hospital care. Well, actually, I think this might be section 4. Anyways, so similar to symptoms, in-hospital care should be documented at presentation, but also daily following that, if possible. But at the very least, at presentation, it should be there. So there's one section entirely on antivenom. So these, the following points appear only if someone selects that yes, antivenom was given. Then they should document things like time from hospital admission to first antivenom administration. Again, I can specify this either in minutes, hours. Oh, Kwaku, go ahead.
So we also realize like antivenom given, delivered, and antivenom prescribed. Didn't prescribed. And so we're also interested in cost analysis. So we should
Yes.
add a prescription. No, the giving should also be there, but they may have prescribed, but the person could not afford.
So separate.
Yes. So yes, because not that the doctor or physician didn't did the work, but the person couldn't afford it.
Yes. That is a very good point, actually. There we go. That's a good point. So only if antivenom was given, then we can document these extra things like time to first antivenom administration, name, number of doses, cost, and whether or not there was an allergic reaction. So we have simple yes or no if there was an acute allergic reaction, what the severity of that reaction was, and then if the person experienced serum sickness or not.
And can we add whether the antivenom was from the hospital stuff?
Was the antivenom from the... Yes, no. Because people buy antivenoms from outside as well.
I think my line was bad, so I didn't hear what you said.
Oh, good. I said I guess people can buy antivenom from outside the hospital as well. That's good to document. Then we have a whole bunch of other supportive treatments.
Hello?
Oh, yes.
And I think it's also important to state whether the antivenom was gotten free or purchased. Because we have interesting findings from our center where you have people that got the antivenom free tend to do better than those that actually purchase the antivenom from outside the hospital.
Is that so?
We have some interesting findings because, the storage and all of other things also plays a vital role, especially when you get it from outside the hospital, where the standard of storage is also very, very important, the temperature and all that. But mostly those that sell it in the pharmacy, some of those things are exposed to extremes of temperature, and then at the end of the day, the efficacy of the antivenom is affected. So in fact, we even have a study from a facility that is pointing to us that those that got free within the hospital had better outcome than those that actually got it outside the hospital.
This is interesting to note. Thanks.
Yeah, good to note that. Then we have a bunch of other supportive treatments. Now we could get into a lot of detail with these, for example, names, doses, things like that. But do we think it's sufficient to document just yes or no whether a patient received other treatments? Because this is a daily field, so we'll know kind of how often these were given. But I will leave that sort of open-ended to see how much detail people think is important to capture for these. Noting the length of the form is quite lengthy already. Mm-hmm.
It looks okay to me. It looks okay to me.
Okay. Yeah. Cool.
Just a quick one.
Yes.
Just food for thought about the types of analgesia given.
Mm-hmm.
Where we have some people prioritizing NSAIDs or things like paracetamol in most of the setups. And we know the effects of NSAIDs on kidney function that may affect outcomes. I don't know if it'd be important to document that or just leave it out, just food for thought or something, some for analgesia.
What was it? NSAIDs? I'm not a medical professional, so I don't know how to.
NSAIDs, non-steroidal anti-inflammatory drugs. You can
Yeah, we
also
can document it.
Yeah. Thank you.
Thank you. Yeah, if these are affect outcomes, yeah, definitely important to document the differences.
That's a very interesting addition. It's a very timely one because actually NSAIDs affect treatment as far as carpet vipers are concerned. So that's a good one. Thank you, sir.
Yeah, fantastic. And then finally, we have cost of supportive treatment as well, if known. And finally, I realize we're at time. We can go maybe just a few minutes over to review this last bit. This is the complications and outcomes. So you can see here, this one is a little bit more, there's more hierarchy kind of in this section. So we have sort of within the institution, whether somebody was admitted to ICU, and then again, we have options for this is not available at the institution. If they were admitted, kind of how long they were there for. Same thing with mechanical ventilation, whether it happened, whether it was not available. Then we have duration. Then we also have dialysis and renal replacement therapy as well. as options. I guess we could document how long somebody was on these as well. And we also have surgical intervention. So if someone received sort of surgical intervention, if they select yes over here, then there's an option to select kind of what kind of surgical intervention was received, whether that's amputation, debridement, or fasciotomy. If there are others we should add, we can add them here. We have an overall duration of hospital stay. Again, we have pregnancy outcomes. I tried to use standard ones here that are kind of mentioned in other documentation, but this is just only applicable for patients who were pregnant. For snakebite outcomes, we have a very simple one to start with, whether the person died or was discharged alive, I should say discharged alive. And then if they were discharged alive, there's options to kind of select what kind of discharge it was, including things like discharge with improvement, whether they were referred to another institution, if they absconded or were discharged against medical advice, and then palliative discharged. And then if someone selects referred to another institution, then there's a further question to ask, if we know what happened to them after that, then we can actually figure out what their final outcome was as well. That's kind of, it's a little bit complex, but I know there was some discussion, there's lots of discussion here going on in the comments about trying to figure out what someone's outcome was. So this seemed like a sort of logical way to find that outcome. And we had somebody suggest adding type of support the patient has following discharge, if known. So they had given some of these suggestions. So, and they noted, these things aren't always collected, but it could be quite informative to have if possible. And then finally, there was a question about long-term complications and whether we should standardize when these are assessed, if there is plan to kind of follow up on these patients. So I'll stop there to see if there's any comments on this or other parts of the final section.
I agree with Beth over there. I think the follow-ups are just a phone call. The patient's number doesn't need to reside in the CRF.
Right.
Yes. So a phone call to the person identify the person's subject. And maybe even if there is a psychological evaluation afterwards, all those, we could add them. It's tedious and read, but when you are looking to comparing data from many regions, it also helps.
Yes, good point.
Before I forget, I don't remember seeing anything on whether the person had health insurance.
Health insurance. Oh yeah, that's a good question. I guess, we could infer that depending on how much somebody is paying for different things. We can kind of add, I wonder if that would fit best here or
At the beginning.
At the beginning. Where are we? Under demographics, maybe. Does the patient have health insurance? Yes, no, it's not applicable in some settings. There we go.
Is it ever not applicable?
I don't know. In some settings, I guess no. I guess everyone has some level of insurance.
Anyway, yeah, by default, I think in some countries by default everybody has a health, but then that becomes yes.
Yes, exactly. Yeah. Okay, then in that case, I think that is it for this. I will leave it open to editing for a little bit longer as well, in case anyone else has sort of burning things they want to add. And then what I'll do, as I mentioned, is this will be kind of shared in a form, a sort of anonymous form, if you will. So where people can kind of vote on each thing included, each data element included, just so we get an idea of what items are higher priority than others, noting that, you know, this is a lengthy form and not everything will be able to be collected in different institutions, so that those with sort of more limited resources can select higher priority items to document. But that'll be coming soon. Were there any last comments on this before we just briefly talk about funding? Okay. I guess we can stop there then. So funding, as far as I know, there is one fund available. Let me share my screen again. I try to keep it updated on this website. So there is a calls for funding page. There's this that's NIHR grant that's available. The deadline's June 4th. Event, page not found. Maybe it doesn't exist. I should update that. But usually we try to keep this as up to date as possible. I know snakebite research specifically isn't always funded. There's the African Snakebite Alliance that often has funding opportunities for snakebite researchers, so that would be a good place to check out as well. But I'll pause here to see if anyone else has any ideas or funding applications that they know about. If they do, feel free to share with others, because yeah, I know what we do is usually not funded. So if anyone has any ideas, this is a good spot to talk about it and share. And if not now, if you think of anything else, let me know. We can always add it to the website so that funding opportunities are advertised as widely as possible. Yeah, with that, I think we can probably wrap up this meeting. Thank you for staying some minutes over. This is a very informative discussion, so thank you all, and we'll see you next time.
Thank you very much.
Thank you.
Thank you. Bye bye.